We are the evidence that self-help works. A review of the history of peer-run programs shows the important role that they have played in the lives of people diagnosed with a mental illness, and the critical role that consumer-led research has played in showing how important establishing the validity of these programs as part of the recovery-based mental health system we are struggling to adopt today. Our history in peer-run programs goes back many years, and I love to quote presidents, in this case Thomas Jefferson, who said, "Who then can so softly bind up the wound of another as he who has felt the same wound himself?" Over the past 3 decades, peer-run programs taking this philosophy of binding up the wound of another have matured, they've diversified, and they've increased in numbers all over the United States. Both social forces and policy initiatives have converged in the past 40 years to foster peer support services as they exist today. The growth of self-help groups, which is one of the important events or social event that occurred beginning in the 1950s, but the growth of self-help groups that addressed a broad range of life crises and medical conditions and disabilities was one of those key developments that helped develop consumer-run programs. Also, the struggle of persons with mental illness to re-enter community life following deinstitutionalization in the 70s. The rise of the mental patients' rights movement, anti-psychiatry and consumer survivor alternatives to traditional mental health treatments. The development of psychosocial rehabilitation programs to address the need for life skills training and socialization. And today, the growing focus on recovery-based services. All are part of the origin of consumer-operated service programs. Beginning in the 1970s, Americans really discovered the power of self-help, in that participation in self-help groups became an important way for people to help each other cope with various problems and life crises. Approximately 7.5 million Americans belong to as many as 1/2 million self-help groups addressing that range of illnesses, addictions, disabilities, and conditions. Self-help has a focus that does not seek to make basic changes in outlook or personality, but to sustain the ability of members to cope with difficult life situations. The two-way interaction of giving and receiving help is therapeutic in itself. And numerous research studies show that participation in self-help groups can help people significantly improve the quality of their lives. Studies show that support groups reduce the need for medical care and hospitalization, and there's ample evidence that has established that personal networks and social activities are important for the well-being of people with mental illness. Researchers have observed that social ties provided individuals with mental illness with opportunities for appropriate behavior and non-dependent relationships and reciprocal social exchange, all of which are essential for living a life in the community. So paralleling the rise of self-help, there were large numbers of psychiatric patients discharged from the psych hospitals in the 60s and 70s, but only to find themselves adrift in uncaring communities, isolated, lonely, and lacking meaningful relationships. Limited financial resources restricted the social activities of ex-mental patients, as fear and ignorance among American citizens stigmatized persons with mental illness and resisted their integration into community life. Media's frequent portrayals of persons with mental illness as dangerous validated that community rejection. It was at that time that early professional psychiatric rehabilitation programs recognized the need for autonomy and free association among individuals who had been socially disabled by institutionalization. Therefore, socialization was taught, promoted, and evaluated as part of rehabilitation initiatives. The clubhouse approach was developed by a group of consumers called We Are Not Alone, WANA, in the 1950s to provide mutual support after they left state hospital. This program was adapted by professionals to build an international therapeutic community called the Clubhouse Movement, composed both of people who have serious mental illness and general staff who work within the clubhouse. Professionally constructed social relationships became opportunities for both the delivery of mental health services and the various types of human interaction. And in the clubhouse, that human interaction was built on the work day. And consumers working through the day at the clubhouse. Lack of understanding, respect, and trust, though, between mental health consumers and professionals prompted persons with mental illness to reject both the clinical and the rehabilitation programs and to develop peer-run alternatives. Early attempts at peer support were followed by the organization of the patients' rights groups like Insane Liberation Front in Portland, Oregon, and the Mental Patients Liberation Project in New York City. The heart of the patients' rights movement was situated within the local group. Started by a small number of people, members would come together through a common sense of injustice and the belief that through organization they could bring about change in the mental health system. Some programs operated within traditional hierarchies with officers and held formal meetings, while others had more egalitarian structures with shared decision-making and no formal leadership. They reached across one person to another person to another person. Activities included organizing support groups, advocating for hospitalized patients, lobbying for changes in the laws, public speaking, publishing newsletters, developing creative and artistic ways of dealing with consumers. The groups communicated through Madness Network News, a newspaper nationally distributed by and for people with mental illness. And they met at conferences. Most important conference was the one funded by the Community Support Program beginning in 1985 called the Alternatives Conference, which still goes on today. A national conference bringing mental health consumers from around the United States and internationally to one place to exchange ideas, to learn from one another and plan for the future. In 1990, Bob Emmerich, did a study of 104 self-help groups and classified them into two major service models. There was the social movement groups, which offered legal advocacy, public education, technical assistance, and information referral networking. 2/3 of the groups were identified in that social movement group. The individual therapy groups, the other model, offered more inner focus individual change through group support meetings. However, at that time, more than 70% of the self-help groups were found to have little to no interaction with mental health professionals. 43% held anti-mental health professional attitudes. That began to change in the 1990s when we moved from separatism to inclusion, from throw away your medicines, don't go to the mental health system, to becoming part of the mental health system. Now that might have been thought of as co-optation, and many mental health consumers said they would take no money from the federal government, that they didn't want to participate in anything that linked them to the traditional mental health system. But others thought by becoming partners, collaborators with traditional mental health services, that they could change the way that mental health services could be delivered. However, they did not start this effort by subsuming their ideas to the traditional mental health system. Rather, they championed the South African disability motto, nothing about us without us, nothing about me without me. They began to emphasize concepts such as service recipient, consumer choice, and treatment partnerships of clinicians and clients within the mental health system. Some consumer leaders started to advocate for consumer inclusion in administration, provision, and evaluation of mental health services as a tool for system reform. Peer support services also began to develop partnerships with traditional mental health providers. And some professional mental health agencies employed consumers in designated roles to provide peer services, such as in case management. And that grew into, today, the peer specialist movement. In 1996, Judy Chamberlain and Sally Rogers and others did a study of drop-in centers throughout the United States, and they found that, different from Bob Emmerich's earlier study, that in the peer-run programs, members used about 7 mental health services in 1 year, and about half were currently taking psychiatric medications. So between the early 90s and the late 90s, we had moved from separatism to inclusion as an approach and a strategy to change mental health services into something that could focus on recovery and empowerment. So rather than developing within the engineered interventions of rehabilitation, a combination of recovery-based beliefs, relationships, and skills emerged from the humanized environments of the modern peer-run support programs, not from traditional mental health programs. The modern consumer-operated service program today is generally defined as a peer-run, self-help organization or group that is administratively and financially controlled by mental health consumers. Most important, they provide persons with mental illness the experience of giving and receiving peer supports in empowering ways. Peer-to-peer supports encourage consumers to confront personal priorities and to rebuild their sense of self and purpose. There is a broad variety of consumer-operated service models. Drop-in centers, mutual support groups, peer educator and advocacy programs, multi-service agencies with benefits counseling and case management, specialized supportive services focusing on crisis respite, employment, housing, and peer phone services or warm lines. SAMHSA estimates in a study done in 2002 that there were 7,467 groups, organizations, and services run by and for mental health consumers or families in the United States. 3,315, or close to 45%, classified themselves as mental health mutual support groups. Another 40% as mental health self-help organizations, and about 15% as consumer-operated services. That meant that almost 39,000 people attended mental health mutual support groups with a mean of 12 attendees per group meeting. And close to 1 million people belong to mental health self-help organizations, with about 319 people per organization. Consumer-operated services report almost 500,000 members. The President's new Freedom Commission on Mental Health's final report recommended that consumers and families are fully involved in orientating the mental health system toward recovery. The formal integration of peer support programs into the continuum of community mental health services promises to improve service outcomes related to recovery and to expand service system capacity. The final report, published in 2003, stated the direct participation of consumers and families in developing a range of community-based, recovery-oriented treatment and support services is a priority. In particular, it urged that consumer-operated services for which an evidence base is emerging be promoted. Along with the development of these programs, consumers and professional researchers begin to study the effectiveness of these programs and to find out if they worked and for whom they work and why they work. The Surgeon General's report on mental health in 1999 recognized the benefits for consumers participating in self-help, consumer-operated programs, and traditional mental health services where consumers are employed as staff. The Surgeon General's report was the first effort to show that mental health services were based on good science. The research on consumer-operated service programs also embraced recovery. One study showed that peer services focus on recovery and suggested that adjuncts and alternatives to formal treatment, involvement in self-help groups, and social opportunities at local drop-in centers foster empowerment and provide opportunities for a more meaningful life. 2 reviews of peer support programs, reviews of the scientific literature, made clear that preliminary evidence supports their effectiveness across a wide variety of domains. Many early studies of peer support services were descriptive or qualitative, seeking to identify participant characteristics or processes that lead to change or consumer perspectives on the benefits of program participation. Studies using non-randomized control groups or pre-test scores as comparisons to post-test scores have found participation in peer support reduces psychiatric symptoms, decreases hospitalization, enlarges social networks, and enhances self-esteem and social functioning. For example, studies of mutual support groups have found that participation in the National Depressive and Manic Depression Association, now known as DBSA, mutual support groups, predicts management of mental illness and that members cope better with their illness and accept their condition. Those who participate in GROW Incorporated meetings show improved psychological and social adjustments as well. Growers, which they're called, spent significantly fewer days in psychiatric hospitals than comparison group and showed increased sense of security, self-esteem, decreased anxiety, a broadened sense of spirituality, and an increased ability to accept problems without blaming self or others for those problems. Gallanter in 1988 found a decline in both symptoms and concomitant psychiatric treatment after joining Recovery, Inc. The Peer Bridger program is another one that shows the effectiveness of peer support. Follow-up rehospitalization rate of matches while enrolled in the Pre-Bridger project was significantly less than baseline hospitalization rate within a 2-year period. That is, during the 2-year baseline period, the matches were hospitalized an average of 60% of the time. While enrolled in the program, however, they were rehospitalized only 19% of the time, and that's an improvement of 41%. Consumer peer specialists and case managers. In a study in 1995, Felton found that clients served by teams of professionals and peer case managers compared to control groups demonstrated greater gains in several areas of quality of life and an overall reduction in the number of major life problems experienced. They also reported more frequent contact with their case managers and the largest gains in the area of self-image, outlook, and social support. Now we come to the turn of the century and the emerging evidence-based practices related to consumer-operated programs. Recent studies based on randomized controlled designs supported the effectiveness, showed that there were significant outcomes produced by peer-delivered service models, such as the Crisis Hostel Project in 2002. That was a research demonstration project which developed a 5-bed residence operated as an alternative to psychiatric hospitalization. And that found that access had better healing outcomes and greater levels of empowerment, access to the crisis hostel, than a comparison group. Length of hospital stays were also shorter and resulted in lower service costs overall. There was in Canada a longitudinal study of consumer survivor initiatives in community health that occurred in Ontario in 2004. Relative to the comparison group, consumer survivor initiatives showed significantly greater reductions in hospitalization and symptom distress, and significantly greater improvements in social support, quality of life, and employment and education. And then finally, the Consumer-Operated Services Program, or COSP, Multi-Site Research Initiative, which began in 1996 and will be rolled out by the federal government in 2010. It was a randomized controlled study of 1,827 participants of 8 consumer-operated service programs, which offered their services as an adjunct to traditional services. And the study significantly showed an increase in well-being, which was defined as recovery, social inclusion, empowerment, hope, meaning in life, quality of life for the participants of the drop-in centers. Throughout the course of this history, both the history of consumer survivor researchers and consumer providers through consumer-operated programs and peer services, we have found that indeed consumers have a key role in bringing us into a recovery-based, consumer-directed mental health system. In the following days, we will understand recovery better and how consumer evaluators in Missouri are going to help the Missouri consumer-operated programs move into evidence-based practices, but they will do it themselves. And they will control their own programs and create a future that's yet to be defined. Because as new researchers, we always have to be open to the unexpected and to new knowledge. Thank you.